Sounds good.
Computer. Okay, we are recording our second of retrocochlear pathology topics in 125, and Angela had a question about a quiz. What quiz was that? Quiz?
Gosh, was that quiz 2 maybe?
Quiz 2?
2 or 3? 2.
Okay.
Or was it 3?
And what was the question then, Angela?
The question was, conductive hearing loss usually presents with a blank audiogram.
Yeah, and the answer to that is a flat audiogram, as opposed to a sloping, as opposed to a rising, as opposed to a precipitous. Okay? And because conductive hearing loss is essentially a plug in the ear. Okay? When you're going out to sit on, to mow the lawn, and you want to protect your ears, you put earplugs in. And when you're putting earplugs in your ear, you are giving yourself a conductive hearing loss on purpose. Okay?
Okay.
So your hearing loss will be flat across the frequencies. In other words, equal in amount for all the different frequencies because you're plugging your ear.
Okay.
So otitis media, wax buildup, anything, otosclerosis, anything that causes a conductive disorder will usually result in a flat hearing loss. It's a good question. I'm glad you're asking it. Well, it's almost humorous to get on OTC emails every day because I'm just realizing these quizzes are just driving everybody bonkers. Actually, Lynn and I are doing it on purpose. It's working. You know,
I saw Miss Roy are talking me off the cliff.
Oh, I had it. It's funny. I saw Renee's last one. I hate to add further to the chaos, but
Hi, Sam.
I'm looking at it with humor because it's the first time that we've ever uploaded these quizzes onto Canvas. It used to be that you guys would upload them and then I would manually grade them. And then we thought, oh, there's a good way to just put them right on Canvas, and then that way they're automatically graded. And I was like, all right. And the devil fools with the best laid plans. I mean, if somebody doesn't put a capital letter, or puts a hyphen or something, the answer's wrong. It's like, oh, right. Come on. So that's artificial intelligence for you. We're going to have to make it. If we did this automatic grading business, we'd have to make all the questions true, false, or multiple choice. And that's a bummer in a way because filling in the blanks is another way of testing. Same with labeling diagrams. That's whenever I make tests up, I always have true, falses, multiple choice, short answer, or fill in the blank, and label the diagrams. And that way you're testing different parts of your brain, and the test has multifaceted nature to it. But who knows? We'll see what goes on. But I apologize for all the hassle this has caused. It certainly wasn't intended. Anyway, good grief. It's kind of humorous, really, when I'm looking at it. But okay, we will finish off our topic on retrocochlear pathology today. I'll share screen, and then I think next week is our last week of class, and we're basically covering pseudohypoacusis. So, looking at retrocochlear pathology, I'll scroll all the way up to the top. We covered these terms last week. We talked a little bit about peripheral and central nervous systems, signs of retrocochlear pathology, that it's unilateral hearing loss. And we talked about the sizes of tumors. And then we talked a bit about true positives, true negatives, false positives, false negatives, and we talked about validity and reliability. So what we'll start on today, and we said a gold standard is a test that's 100% sensitive and 100% specific. So now with that in mind, looking at those properties of a test, and we said that retrocochlear pathology is really the testing ground of tests. I mean, because tumors are hard to find, unlike a pure tone test to find conductive hearing loss or whatever. If you're looking for a tiny little tumor, tests are only so good, and you have to usually use a battery of tests in order to come up with a real solid answer. But we do that with all of our testing anyway. You've got pure tone testing, you've got speech testing, We do tympanometry because no test stands completely alone and by itself. So tests are hard pressed to be 100% sensitive and 100% specific. But let's concentrate on retrocochlear pathology right here. And let's, yeah, Angela.
Renee, will you mute? Thank you.
Yes. Ah, okay, we're good. All right, cool. Share screen. Renee was misbehaving. All right, cool. All right, that's me all the time. Okay, so look at tests for retrocochlear pathology that I have highlighted right here. The best ones are radiologic, CAT scans, MRIs. And of the two, MRIs are better. So look at what they stand for: magnetic resonance imaging. CT scans, they just put an A in there so you can say it like cat, okay? I remember, and this is just kind of strange, this is when we first landed on the moon, 1969, I believe it was. I was just a teenager standing in the front yard, and I remember on TV, they called that lunar lander, they called it the LEM, L-E-M. It was the lunar module. But someone didn't like the fact that they put an E in there to call it the LEM. That's disrespectful. You can't be making a short little nickname out of something that someone might get killed in. We got to revert back to its original initials, the lunar module, the LM. We can't go around calling it the LEM. I find that kind of like a parallel in a way to CAT scans. Computerized tomography is what CT stands for. They just put an A in there so you can say it, cat, okay? Anyway, MRIs are better. They are mo beta. They show the gray and the white better than CAT scans do. And they can detect tumors more easily, okay? CAT scans are cheaper. They're not bad, but they're a little bit more hazy. They just don't quite have the definition in them. And just for the heck of it, I might just for the heck of it. No, Sam, I'm not talking. I was just saying the Sam Hill. What I'm going to do is I'm going to pull up a PowerPoint here. And you may or may not have seen this before. I can never always remember this stuff. But let's just pull up a particular PowerPoint here that can show some of the differences between, and here, let's do this one. This is my, you're going to see CAT scans and MRIs on this particular PowerPoint. And the first one you're going to see is mine. You can see my CAT scans of my brain, okay? And you could see it sliced down. I had real bad headaches, and I thought I had a tumor. My father had passed away of a brain tumor, and turns out I just had one too many drinks the night before, so it was my own fault. But nonetheless, there's a CAT scan of Ted's brain going down, down. You can see the eyes now, okay? Here's my daughter, Catherine, when she was a young, tiny little thing. She was born with a malady called Aicardi syndrome. She's recently passed away just of this September, but she lived to be 23. And this is her as a teenager, as she's getting older. Now, this is a CAT scan done at the East Alabama Medical Center of her brain. Can you see how it's lopsided? Okay? You can see the gray and the white matter. That's a CAT scan. Not bad. You can see where she's missing part of her cerebellum here. So she had brain disorders, and you can also see now the lenses of her eyes. Now this is an MRI, okay, and it's done from the front. It almost looks like Darth Vader on the top here. Okay, but now you're look at how the gray and the white areas are much more defined with an MRI. Way less blurry, okay? So now you can look down with an MRI. Here's a CAT scan. Again, they're going to show you the layers that they took. See how blurry that is? It gives you the idea. You can see gray and white. You can see it, okay? And you can, this is all CAT scanned. But when you're looking at MRI, it's just a little, look at this. See how much more detailed it is? Which you can see the differences between the gray and the white matter. Notice how the gray matter is like a thin layer of tissue on the outside of the cortex, and the white matter is inside. You can think of gray and white matter almost like cauliflower or broccoli. When you slice it, and you can see the florets at the top, and then you see the big stalks going in. The stalks would be the white matter, and the florets would be the gray matter. In fact, anatomists often compare the brain, and they talk about cauliflower or broccoli because it's a nice kind of a floral imitation of the brain. But see that you can see how MRIs are much better that way. So I'll stop sharing here. We'll go to, well, why stop sharing? Let's all share. It's always good to share. But let me just kind of get out of this so that I can look at our notes back here. So, MRI with gadolinium dye. Okay, the dye, they squirt that in, and that helps to even increase the contrast between gray matter and white matter. That's the gold standard, okay? That's the best. The hit rates, in other words, true positives right here, and correct rejection, true negatives, are like 99%. So that's the test of all tests. That's the mother lode. Now, when you look at ABR, this is a test that audiologists do. It's pretty good. It doesn't have quite as good a hit rate and correct rejection. When you're looking at hit rate and correct rejection, please think of those as true positives, true negatives, okay? Hit rate, correct rejection, same, those are synonyms for true positives, true negatives. So those are pretty good. And when you're looking at an ABR, let's look at ABRs and see what they look like, so that we can kind of make this a little bit of our friend. And I'm going to pull this picture up right here. And your textbook, Martin, Introduction to Audiology, probably has this picture. At least this is where I got it out of an older edition. Now look at the right and left, ABR. First of all, know what the term stands for. Auditory brainstem response, ABR. Auditory brainstem response. And to do an ABR, and students at Missouri, Missouri State University in Springfield are learning how to do ABRs. That's one of their classes that they take. It's called electrophysiology. And what's done with an ABR is an electrode is put on your earlobe and another electrode on your other earlobe, and then an electrode right between your eyes, and then a fourth one right at the hairline, right here. Now the electrode between your eyes is just a ground, but they're looking at what's going on between this electrode and here, and this electrode and here. Because you're looking at the eighth nerve, 1 inch long, going horizontally in toward the brain stem, and then the brain stem itself, which is about 1 inch long. So you're looking at inch horizontal, inch vertical. A diagonal, so and then they're looking at the diagonal between here and here, and then here and here. And then what they're doing, they put headphones on, and what comes out of the headphones, first in the right ear, then in the left ear, are what's called clicks. Now, I can give you an example of a click. Here. I'm making clicks. And that's all the sounds are. Hundreds of them, just. And gradually, you begin to see 5 peaks on your computer monitor. And that's called the ABR. It's really cool. It emerges like out of a fog. Let's look at the top right. On here, actually, I'm looking at the left, if you know what I mean. You'll see 5 bumps labeled with Roman numerals. 1, 3, and 5. Well, they come from places. Peak 1 comes from where the 8th nerve touches the inner hair cells. Okay, it's by the spiral ganglia, right where the 8th nerve is at the cochlea. Peak number 2 is where the 8th nerve meets the brainstem. And the first nucleus that you remember from 120 anatomy class is called the cochlear nucleus. So the spiral ganglia and the cochlear nucleus are 1 inch apart, and they bound the eighth nerve like bookends, okay? So the eighth nerve at the cochlea, peak 1. The eighth nerve at the brainstem, peak 2. Peak 3, superior olivary complex, the next pit stop up the brainstem. Peaks 4 and 5 they come from the inferior colliculus, the top of the brainstem, or the top of the auditory areas there. So you've got these various nuclei or pit stops: cochlear nucleus, superior olivary complex, lateral lemniscus, remember that? Inferior colliculus. Well, peaks 4 and 5 kind of come from the lateral lemniscus and the inferior colliculus. So they call it auditory brainstem response. Now look what you see here. At 80 decibels, you saw all peaks. At 60, you saw all peaks. At 40, they were there. And finally, at 20, only peak 5 exists. Can you see that just as a little bump? Well, this is a test whereby we test infants. This is one other test besides otoacoustic emissions, whereby to test people who can't tell you what they hear, the ABR. And look at the left ear, same thing. All the bumps at 80, you can see peak 1 kind of disappears at 60. That's okay. Peak 4, you only see peak 5. I mean, at 40, and at 20, you still see peak 5. That means the person can hear all the way down to 20 decibels. Pretty darn good. So this application of the ABR is done for threshold testing for people who cannot or who will not respond behaviorally by raising a hand or pushing a button. So this is a great test for malingerers, liars. It's a great test for infants, okay, or children who can't tell you what they hear, or for mentally disabled people, ABR. You lay there in the chair, it takes about 10 minutes, you're done. But look at the next application of ABR. This is for brain tumor finding, or eighth nerve tumors. So look at the right ear. All 5 peaks there at 80 again. You go down to 60, you still see some peaks. Go down to 30, you can still see a peak 5. Good. Now the left ear. And it may be that the left ear didn't have much of a hearing loss at all, but the person was reporting ringing in the ear, in that left ear, dizziness. Remember we gave you some of the symptoms of an eighth nerve tumor? Could be a 30-year-old mother of 3 kids saying, yeah, just over the past half a year, I just can't talk on the phone in this one ear. And you've done a case history and there's no ear infection. You've done a tympanogram, normal, type A, there's no air bow, or there's no conductive hearing loss. And then you did SRT, speech reception threshold, and you might have found, yep, it agrees with the pure tone average. Let's say the person has a slight hearing loss. Let's say the eighth nerve tumor did this, gave this kind of hearing loss. Let's just pretend here, so we don't have a huge deal. I'll just show you. An eighth nerve tumor can result in just a mild hearing loss. Here. I call this person, uh-oh. Okay, let's get that crazy bar out of the way. I hate that. Go away. I call the name of this person, uh-oh. Okay, eighth nerve tumor, left ear. The hearing loss doesn't have to be much. It can be, but it doesn't have to be. It can be almost any kind of a degree, okay? So this might be the situation for this person. So now let's go and look at the ABR. So in the left ear, even with that small hearing loss, look at how far peaks 1 and 5 are apart compared to the right. They don't look like each other's. And then you go down to 80, because they started out at 90, and you went down to 80, and the whole ABR is breaking down. And at 70, it's gone. That, Houston, spells trouble. Okay, the ABR should still be visible with a 30 decibel hearing loss. That's not that much, but hey, with an eighth nerve tumor, the whole ABR broke down. The ABR is a wonderful test. It is, once again, non-behavioral. And that's what you want. So non-behavioral tests are the best. MRI, CAT scans MRIs are best. CAT scans, second best. Third best, ABR, not bad, can't complain. And I'll show you another non-behavioral test of eighth nerve tumor. And it's called acoustic reflex decay. So here you go. It's got 4 little bars on here. A is the stimulus. So what you're doing is tympanometry, and you're doing acoustic reflexes. You've done tympanometry and you've got a type A tympanogram, normal, which is all good. Now you're leaving the probe in the ear and you're delivering a loud sound through that probe, and you're causing an acoustic reflex. So remember from audiometry class, I should ask you, have you guys taken audiometry? I can never remember. You have, good. And when you're doing tympanometry, the last part of tympanometry is the acoustic reflex. And when you've done tympanometry, right, you've changed the air pressure and you have that tone constantly bouncing off the ear and you're finding out where the peak is, blah, 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 all of that stuff. Say you've done the tympanogram, leave the probe there, and now you're doing acoustic reflex testing. And a loud sound might come from the opposite headphone or through the probe itself. And you're looking to find out, did the tympanogram change as a result? Did your static compliance, the height of your tympanogram, did that change for a split second? If it changed, that meant your acoustic reflex occurred, right? Your tensor tympani muscle and stapedius muscles pulled. Because what is the acoustic reflex? Outer ear canal, middle ear, inner ear, hang on, what part? Inner hair cells. Eighth nerve, that's the afferent brain going part. Then now you're at the brain stem, now you're going efferent back out. The 5th cranial nerve attached to the tensor tympani muscle, the 7th cranial nerve attached to the stapedius muscle, and those 2 muscles are the acoustic reflex. Well, you're putting a loud sound through the tympanometer probe. Did the tympanogram change as a result? I didn't go left or right. I don't mean that because it's not air pressure. You're changing the tympanogram height. And you're doing that because you're causing an acoustic reflex. And the acoustic reflex makes the middle ear even more stiff for a split second because those muscles are pulling. And that increased stiffness of the middle ear causes more sound to bounce back off the drum, which means essentially your tympanogram didn't change because of air pressure changes. You've left the air pressure at room air pressure. You're just changing the tympanogram by means of a loud sound. So the acoustic reflex is also a non-behavioral test. And in eighth nerve tumors, it's usually absent. Okay? Even though you should still have it with a 30 decibel mild hearing loss, it's gonzo. Okay? Well, hey man, the acoustic reflex is also gone with conductive hearing loss. So again, it shows you how no one test stands by itself. So now you've got to add another wrinkle here, and they do what's called the acoustic reflex decay. And this is not something the HIS does. The audiologist usually does this, but you're doing the acoustic reflex, but you're keeping the tone going. Look at what it says here in black. That's the tone, the loud stimulus that causes an acoustic reflex. Only instead of just giving it for a split second and looking for a change in the tympanogram, they're holding the bar down for 10 seconds. And here's the acoustic reflex pulling in. You can see, this is just telling you the change in the tympanogram. It's just saying there's a change in the tympanogram, and that change is holding for the whole time I'm presenting the stimulus. That's a test that's called acoustic reflex decay. Okay, so slide B or panel B here is normal. Now look at C, panel C. And when you're looking at panel C, you can see how the acoustic reflex gets weaker. It's decaying. And look at panel D. You've kept the tone going for 10 seconds, but look at this. the acoustic reflex, like doing chin-ups. It just couldn't hold on. So you have lost the acoustic. You may have had an acoustic reflex at first, but it couldn't hang on. And that's a sign that the eighth nerve is tired. It's taxed. There's a tumor, and it can't maintain its role in the acoustic reflex arc due to a tumor. So look at all these tests: MRI, CAT scans, ABRs, acoustic reflex decay. Those are the better tests. Now let's go to the lousy tests. Not pretty, because a lot of people used to do these tests, and they don't really so much anymore. These are behavioral tests, word recognition, speech discrimination. Okay, in the bad ear. Is it always really bad? Not necessarily, but it's a behavioral test. Look at the second one, tone decay. Tone decay, you know what that is? I'll show you what tone decay is. Okay, sir, your left ear seems to have a problem. Here's what we're going to do. I'm going to present a loud tone to that left ear. I want you to hold your hand up as long as you hear that tone. So 120 dB. And the guy's got his hand held up. And the theory was, if he had an eighth nerve tumor, the eighth nerve would overload and the guy wouldn't hear the tone anymore. And he put his hand down. Tone decay. Yikes, I think I'd put my hand down too to stop getting from noise-induced hearing loss. You know, see what I'm saying? Behavioral tests are not as good as non-behavioral tests. They are not sensitive, nor are they specific. And that's the grade sheet you're putting all tests on. So tone decay is a terrible test. It's probably the worst. Speech discrimination, kind of 50, 60%. You know, it's okay. It's fairly sensitive, fairly specific, but not everyone with an eighth nerve tumor is necessarily going to have terrible speech discrimination. And then what are you going to say is terrible? 50%? 40%? 60%? What's your rule? So this is kind of how you got to look at things that way. And you're breaking things down into behavioral and non-behavioral. And when it comes to retrocochlear pathology, non-behavioral tests are best. All right, share screen again. Let's look at the notes so we can get on through. Cost-benefit analysis of hospitals, of course, has to always be taken into account. MRIs are hard to get to. High costs. ABR is cheaper. In audiology, the best tests for retrocochlear pathology are non-behavioral. There you have them. Audiologists don't do CAT scans. Audiologists don't do MRIs. Audiologists do ABR. They do acoustic reflexes, and they do acoustic reflex decay. With retrocochlear pathology, speech discrimination is abnormally poor, usually. Okay, it's not very sensitive, not very specific, but better than a poke in the eye with a sharp stick. Again, the results will be unilateral, as eighth nerve tumors are one-sided. The sensory neural hearing loss may not even be that bad, but the speech discrimination may be alarmingly bad for the hearing loss that you're seeing. So for that 30 decibel hearing loss I showed you, the speech discrimination, which should be around 80 or 90%, is maybe around 60 or 40%. Okay, that's a sign of eighth nerve pathology. Please refer. Speech discrimination testing is a behavioral test. Now you'll see something called rollover. And this was a theory done in speech recognition testing. Let's see, rollover. Here you go. Oh, gosh. The term rollover, okay? I always say fat and skinny went to bed, fat rolled over, and skinny was dead. Okay, rollover. So remember, we're talking about how someone does as a function of the intensity of the speech. word recognition. Once it's about 40 dB above your thresholds, you're doing almost 100% for normal, okay? For showing you sensory neural loss, you'd look at this curve here. As you got louder, you did better, but finally you plateau off and you never really do 100%. You get close to it for a mild to moderate typical sensory neural loss. Rollover is the one on the right. It was a sign of eighth nerve tumors as well, saying, hey, when I increased the intensity, my performance got better. Remember, here's your recognition score. Performance is on the vertical. I got louder. My speech discrim did better. But look, all of a sudden it rolled over, roll over. So it's saying you're overloaded the eighth nerve, and now with increased intensity, it actually did worse. Okay? That's a behavioral speech test for retrocochlear pathology. So now you've got a few different tests that are non-behavioral or that are behavioral for retrocochlear pathology, and you can name them. One test that's behavioral is pure tone testing, asymmetrical sensory neural loss. A second test that's behavioral is poor word recognition in speech discrimination. A third test would be rollover. In other words, do your speech discrimination at MCL plus 10. Do your speech discrimination now again at MCL plus 20. Do your speech discrimination again at MCL plus 30 and start to see rollover. In other words, decreased performance. Okay? So rollover would be another kind of like a wrinkle on speech discrimination, just like acoustic reflex decay is a wrinkle on acoustic reflex testing. Okay? These are extra added wrinkles on commonly used tests in order to look for eighth nerve pathology. So think about it that way, and I'll stop sharing so we can really make this point. Speech discrimination is a behavioral test to look for retrocochlear pathology, and what's the sign? Poor scores. And then a wrinkle you can add on to it is do it again at a higher intensity, and do it again at an even higher, and do it again at an even higher intensity, and look for rollover. Okay, that's the wrinkle on speech discrimination testing, to look for eighth nerve pathology. And when you're looking at acoustic reflexes, well, that's done commonly anyway in a test, but a wrinkle of it is, oh, has the guy got absent acoustic reflexes? Well, then I can't really do acoustic reflex decay because the guy doesn't have acoustic reflexes. But if the guy does have acoustic reflexes, and you still think there's eighth nerve pathology, then you'd do acoustic reflex decay. You'd hold the tone for like 10 seconds, and you'd look for the acoustic reflex to die out. Again, acoustic reflex decay is a wrinkle or an added thing done onto a commonly used test called acoustic reflexes for the purpose of assessing eighth nerve tumor. Okay? So, and a fourth behavioral test that's really bad. Okay, so you had pure tone asymmetry. You've got poor speech discrimination. You've got rollover. And then, of course, the worst one is that tone decay. Absolutely stupid test. Please don't. I've never done that test in my life, but you'll still see it talked about in old manuals, and you're going to run into the term once in a while. It's historical. People don't do it anymore. All right, good stuff. We're moving right along. This is all good. So now you'll see that whole bottom part here. You can see where I'm talking about rollover here, old test. Poor, not very effective, poor true positives, poor true negatives. Most older behavioral tests have become unnecessary. Otoacoustic emissions, by the way, are lousy at testing for retrocochlear pathology. They are a test of outer hair cell function, and the eighth nerve is associated with inner hair cells, not outer hair cells. Okay, so OAEs have nothing to do with looking for retrocochlear pathology at all. It's just, remember, the eighth nerve communicates with the inner hair cells, not the outers. And then you'll see a little paragraph here on acoustic reflex and decay. We talked about it now. but this is the write-up of it. You can read that. We've already discussed it, but there it is in writing for you. And then the very bottom of the page here of page 2 talks about ABR. And again, look what it says here. Done for 2 reasons. 1, to determine hearing thresholds if these cannot get obtained behaviorally, and to see if there's an 8th nerve pathology or a pathology of the low brainstem. Those are the 2 reasons. Put a star by that. 1 is to test hearing, and the other use of the ABR is to look for 8th nerve tumors. Now, when you're looking at ABR here, before we leave the topic, and you're looking at an ABR, okay, can you tell me what you might think is a downside of this test for testing for thresholds? What do you think when you're looking at this? You think, oh, that's pretty good. But one thing that might stand out is, what frequency are you testing? Are you testing 250 hertz, 500 hertz, 1,000, 2,000, 4, 8? Who knows? It really hurts. So the downside of ABR is it's not frequency specific. Basically a click, when I'm doing this, basically the frequencies are somewhere between 1,000 and 4,000 hertz. So ABR gives you a rough idea of how the baby might be hearing anywhere between 1,000 and 4,000 hertz. But other than that, it is not very frequency specific. So it too has its downside when you're checking for hearing thresholds. And the downside is frequency specificity just isn't there. All right. So tests for retrocochlear pathologies: speech discrimination, tone decay, acoustic reflex, ipsilateral and contralateral, and I forgot to put acoustic reflex decay, ABR, CAT scans and MRIs, and the one thing we haven't talked about is the very last one, central auditory processing disorders. There is one picture here I want to show you, and it's this one here. It's an important picture. It's in your PowerPoints too. Okay, and then we will leave page 2, and we will finish this topic on retrocochlear pathology. This picture is showing you, look at its axes, the hearing loss level, and then the vertical axis showing you the percent of times that the acoustic reflex would be absent. Okay, and you're looking at 3 different types of hearing losses: conductive, cochlear or sensory neural, and the last one says CN8. That stands for Canadian National, no, I'm teasing, cochlear nerve, 8th nerve, okay? That's what that stands for. So conductive hearing loss, sensory neural hearing, or 8th nerve tumor, which causes a sensory neural loss too, but they're just trying to differentiate between the 2. If you have a conductive hearing loss of even 20 decibels, an air-bone gap, you'll have a 40% chance of having absent reflexes. By the time your conductive hearing loss gets to be about 40 decibels, you've almost certainly lost your acoustic reflexes. So conductive hearing loss obliterates acoustic reflexes. Now look at sensory neural. You should still have acoustic reflexes. Percent of absent acoustic reflexes, almost 0% until the loss gets to be around 60. How come? That's the elbow. Remember, outer hair cell pathology causes a mild to moderate sensory neural loss. By the time your hearing loss gets to be 50 to 60, now inners are beginning to be involved. And once you've got inner hair cell pathology involvement, now you've got a lack of acoustic reflexes happening. So now with severe sensory neural loss, you have a high percentage of absent acoustic reflexes. Contrast that to 8th nerve tumor. By the time you have almost any hearing loss due to 8th nerve tumor, you have a rapid onset of absent acoustic reflexes. And that's what this picture is telling you. Okay? 8th nerve tumor is associated often with absent acoustic reflexes, more so than typical general sensory neural loss is. Just wanted to show you that. This is a story here of a person with 8th nerve tumors. And I've included this slide and this one. Shall we read it together? It's a trip. This one here will blow your mind, okay? This is a story of a young lady who got acoustic tumor in Toronto, Ontario, Canada. And I'll go over it very quickly with you. Acoustic neuroma caught our family completely by surprise, despite the slow progression. In 1992, my wife Linda began to experience balance problems, loss of hearing in her left ear. Family doctor thought it might be an inner ear problem like labyrinthitis, an ear infection, you know, a viral infection of the cochlea. Suggested she stop taking salt and coffee. Oh boy, that would be a bummer. I'd be really in trouble without coffee. Now, basically they recommended a BAER, which is an ABR. They called it a Bayer test. The test, which typically should have detected the tumor, was inconclusive. See? Not 100% sensitive, not 100% specific. Within a few weeks, the symptoms subsided. The salt and coffee must have been the cause. In the spring of 1994, she began to notice a loss of sensation in her teeth, gums, and tongue. Her doctor suggested she check with a dentist, who referred her to an oral surgeon. Took a few weeks of appointments, unable to determine the cause of the symptoms. Finally referred to an ear, nose, and throat doctor, who sent her for a CAT scan. It revealed a 3-centimeter tumor growing from her auditory canal, internal auditory meatus, inward, along the auditory nerve. We were stunned by the diagnosis. Our 2 teenagers thought we were looking for a simple problem. No, neurologist told us more about her acoustic tumor. They obtained support from the Acoustic Tumor Society of Canada. It's a benign tumor that grows around the nerve sheath. They're talking about what it does, growing slowly, putting pressure on the nerves in the opening. In other words, an 8th nerve tumor may often be associated with weakness of your cheek. Because what also comes through the internal auditory meatus is the 7th cranial nerve. And if the tumor's pushing on the 8th cranial nerve, it's going to squeeze the 7th as well. So your acoustic reflex will be affected, but also the 7th nerve controls your cheek muscles. So the person is going to have weird facial paralysis. Ooh, so, okay, one of the things that can happen, here we go. Basically, so as the nerve sheath is compressed, it causes deafness, loss of facial sensation, ringing in the ears, other symptoms. If left untreated, it can kill you. Statistically, 1 in 100,000 people has it. The treatment is usually surgical. Her operation, check this out, lasted 9 hours. They cut through her skull to gain access to the tumor. They had to remove the tumor piece by piece. She started to get a lot of bleeding. They had to cauterize the blood vessels. And the result was a partial facial paralysis due to traumatization of the nerve. So here's this lady now with what looks like Bell's palsy. The face is pulled over to the side. Terrible. So was it permanent or temporary? She had intense headaches, poor balance, lack of energy. She began to deal with the loss of hearing in her left ear because, yes, they had to kill the cochlea to get through to the 8th nerve, so her left ear was deaf. She had lost a significant amount of control over the left side of her face and eye. She went to physiotherapy for 6 months to a year. She started to get control of her facial muscles again, but her facial paralysis proved to be one of the biggest obstacles she has struggled to overcome, both physically and emotionally. The lack of self-confidence in her appearance has caused her to withdraw from situations affecting some of her relationships. Despite assurances that the paralysis is not obvious, she still fights with that ongoing internal battle. So there's a lot of 10 years after the operation, she continues to work to counter the effects of the tumor and the surgery. Has learned to compensate for one-sided hearing loss and lingering dizziness. Works daily to maintain symmetry of her face. through facial stretches and exercises, continues to work on rebuilding her self-confidence. So you can really see that the results of an eighth nerve tumor can be pretty brutal. So basically, this is just stuff in here for your own. We talked about gray matter and white matter and things like that. You don't have to memorize this stuff. This is more for 120 and not so much for 125 hearing disorders. But it's basically to give you an idea of the brain stem, which is about 1 inch long, and the eighth nerve is about 1 inch long. So again, just showing you these things. Here's the eighth nerve, about 1 inch long, your brain stem, about 1 inch long. Think of horizontal and vertical. And the ABR is checking that right angle structure, but with an electrode on the top of the forehead to the earlobe, or from here to here. So this is all a different world. Now, we move on to finish this section, okay? It's called central auditory processing dysfunction. It is in your notes on page, so I've left this all here on ABR, and again, this is verbal stuff, but we've basically covered this, but make sure you have a read of it, because it repeats what we've spoken about so far, okay? Here's where you get to the final part here. Audiometric tests for CANS, Central Auditory Nervous System. And this is no longer eighth nerve and brain stem. Now you're going to the brain. And there's not really a lot of auditory pathology of the brain, except one in which many people get accused of in relationships. You can hear, you're just not listening. Okay? Think about it. What's the difference between hearing and listening? Listening means you're paying attention. Hearing just means you're a sound. You're aware of sounds. Listening means your focus, your brain is behaving. The kid can hear, he's just not listening. Learning disabilities in the classroom. CAPD stands for Central Auditory Processing Dysfunction. And it's more common in little boys than in little girls. And it's the little boys are bouncing off the frickin' walls. Sometimes they call it ADHD, attention hyperactivity, something disorders, or ADD, attention deficit disorder, or LD, learning disability. Or, there's all these terms. It depends on whether you got assessed by a teacher, a psychologist, a medical doctor, or an audiologist. If you were assessed of this by an audiologist, it would be called CAPD. Hearing, not listening. You know what they do? They do a test often called dichotic digits. They'll put a pair of digits in the right ear and a pair of digits in the left ear. And the child may have normal hearing. The audiogram may be completely normal, but he's bouncing off the walls and the teacher can hardly control the kid. The test that's done for this is often called dichotic digits. Let's look at what they do. It's really wild. Oh, here it is. There's the guy. There's the little kid. The little fart. All right. Sit down. All right, kid. We're going to put headphones on you, and you're going to hear digits. And the digits are going to be between 1 and 10. But we're not using the number 7 because 7 has 2 syllables. But 1, 2, 3, 4, 5, 6, 8, 9, 10. These will be randomly presented to your ears in pairs. So you might hear, for example, 1, 9 in the left ear and 6, 4 in the right ear. Different stimuli to the ears at the same time. Do you remember in 110 we covered the terms monotic, diotic, dichotic? Remember that? Dichotic, and I gave you an example of dichotic. Different sounds to both ears at the same time. In other words, and think of how irritating this can be. You're on the phone and your cousin is trying to find his way into town. I'm parked here at the gas station, yeah, and I just can't quite find my way over to your house. And you're going, well, tell you what, take the second stoplight, and when you get to the second light, turn right, and your wife on the phone is going, no, 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 she's in the kitchen. That's the wrong way. They're going to get confused. Tell them to go. And you're hearing the person in one ear, and you're getting conflicting information in the other ear, and it's, dichotic is not a comfortable thing, okay? It's an unnatural listening situation. And that's why they use it. They're trying to tax the system. They're taxing it. A chain is as strong as its weakest link. So the kid hears digits, and they're coming out in random order in pairs, a pair to this ear and a pair to this ear, and the kid just has to repeat what they are. Doesn't have to tell you the order, just what numbers did you hear? And that's the task of dichotic digits. So when you're listening to this, the kid would have to say 6, 1, 4, 9. Yeah, yep, good kid. All right, here's the next pairs of dichotic digits. So they do this about 20 times. And what they're looking for is to find out if there's a difference between the ears. Well, here's what happens here's the assumption behind dichotic digits. Let's look at this once, because what happens here is this. You've got a right ear in red, a left ear in blue, okay? And here's your pairs of digits. Look at the pairs. It might be 4, 3, 9, 2, could be 8, 6, 5, 1, could be 1, 5, 8, 3, doesn't matter. The point is they are simultaneously presented to the left and right ears, but look at what happens here. Number one, information. Anytime, there's two assumptions here. And I'll stop sharing for just a second, just to really highlight this. This is well known in speech-language pathology too. The left hemisphere in most people is dominant for speech. You've got right and left hemispheres, your auditory areas, remember the temporal lobes, Heschel's gyrus, remember we covered that in anatomy? Those are the auditory areas of the cortex. Well, the left auditory cortex is usually larger than the right auditory cortex. And the left auditory cortex is usually dominant for speech, at least in most right-handers. In left-handers, they're usually equal. But in right-handers, the left is dominant for speech. That's one assumption. So when you're looking at the dichotic digits test, watch what happens here. When you've got dichotic information taking place, look at the pathways that you can go to the brain, ipsilaterally or contralaterally. So contralaterally, ipsilaterally. In other words, the brainstem is so complex with all those weird nuclei that information is doing this, going up to the brain. It's going up the same side, but it's also going contralaterally. And same with this ear. It's going up to the brain same side and also contralaterally. Well, during dichotic listening, and only during dichotic listening, the ipsilateral pathways are suppressed and the contras rule. Okay, that's one assumption. That's the second assumption. The first assumption is left temporal lobe is dominant for speech. Second assumption, during dichotic listening, and only during dichotic listening, the ipsilateral pathways are suppressed, the contras rule. All right, now back to the picture. Here you go. Dichotic information, the right ear information goes contralaterally to the dominant left hemisphere. Those digits are remembered. Okay, but look at the left ear. It has to go to the non-dominant hemisphere, and then it has to cross the corpus callosum to get to the dominant hemisphere. So the left contralateral pathway has a longer route than the right contralateral pathway. Remember, during dichotic listening, so here it is, here's the two assumptions. Left temporal lobe, blue, is dominant for speech and language. And number two, during dichotic listening, the contralateral pathways suppress the ipsies. So what happens here is you're going to have a right ear advantage due to this scenario. So look where the crossovers are occurring. They are occurring in the brain stem, but also at the corpus callosum. And when you're looking at the corpus callosum, let's look at a picture of that. Here, this is showing you a schematic. Here's the 8th cranial nerve, crossover, crossover, and then you've got this corpus callosum in the middle, okay? And when you're looking at things here, here's the corpus callosum. And when you're looking at things here, here's the corpus callosum. And here, now a sagittal cut, corpus callosum. The corpus callosum is a white matter tract that is between the hemispheres, and it allows the right and left hemispheres to share information. Okay, so you've got the brainstem crossovers, but then you have the corpus callosum, which is that bridge that links the right and left hemispheres. So in little kids, that isn't done yet. That bridge isn't finished. And it finishes quicker in girls than it does in boys. So even in normal hearing people, grown-up adults, will have a slight right ear advantage. In dichotic digits, I'll probably have like 54% right ear and 46% left ear. I'll remember most of them to the right ear, not quite as many to the left ear, because of that picture I just showed you, that the right ear has that straight contralateral pathway to the dominant left hemisphere and the left doesn't. But in a child whose corpus callosum isn't finished yet, that kid's going to have a huge right ear advantage because that kid's corpus callosum isn't done yet. And because it's not finished yet, hang on here, we go to this end, whoops, because it's not finished yet, this corpus callosum, the right ear is going to get everything and the left ear is going to get diddly. And you know how they figured this stuff out? They figured this stuff out when they did split brain surgery for epilepsy. And they would cut or sever the corpus callosum for epilepsy. They literally would go in and surgically cut the corpus callosum in half. And when they did that, they did dichotic digits on the person, and sure enough, the callosal section, the guy had a huge right ear advantage and almost nothing in the left ear. And that's how they kind of figured this stuff out. So what happens, to summarize here, is that with learning disabilities in schools, if the child is sent to an audiologist for central auditory processing assessment, they'll likely do a test called the dichotic digits, and they will look for a huge right ear advantage. And if they see a huge right ear advantage, they'll go, yep, the kid's got, his corpus callosum isn't done yet. He's got a central problem. Maybe what we've got to do is preferential seating in the classroom. He needs an FM system. He's got to have the teacher really engaged in teaching him. Let's keep it common sense. You know what? A lot of times their test isn't valid. A lot of times they aren't testing what they say they're testing. You know what they're often testing? They're testing gender. Think about boys growing up versus girls. Who learns language quicker? Girls. Who colors within the lines better? Girls. Who bounces off the walls the most? Boys. Is that because they're learning disabled? I don't know. You've got, and boys do develop the corpus callosum later than girls. Yep, that's true, but it doesn't mean they're disabled. They're just men and girls are girls. They're just different sexes. So when you think about 40,000 years ago, when we lived in caves, or if, I'm making up a story, some people are biblical creationists, but think of the example, okay? Cave people. And the women and children are sitting there listening to stories over the fire. the crackling embers of a fire. What do you think the men were doing? They're probably doing anything but listening. They're probably faced outward with their spears to protect against marauding animals. They're not wired the same. And when you think about our general array in society, you have girly girls, you have tomboys, kind of masculine girls, you'll have effeminate guys, and then you'll have guys. I mean, we've got a whole rainbow out there. And think about these guys that are in trouble in school, and the teachers are failing them, and the guy gets pissed off, and he decides to quit school for a while or bags it out. He's hanging out at the mall, smoking dope or doing drugs or whatever, gets picked up for breaking and entering. Okay, now he goes to juvenile detention hall, and now he's wearing upside-down cross earrings and screw-off buckles and getting tattoos, and he's in trouble. And this whole cycle has now happened. Finally, a decent judge says, "Kid, you're going in the Army." And the kid's got 3 square meals a day, a rigid routine, and he ends up being about the best helicopter pilot out there. He's skilled. He's very good at video games, excellent at catching a ball, knows exactly where things are going to be in space, because the right hemisphere, the non-dominant hemisphere, and the left, they're not communicating the same way that is done in a little girl. He may end up being an artist, an excellent sculptor. He may know shapes. There's different kind of brain. No, not so good at reading, not so good at digesting novels, and but he's smart as a whip. Most kids with learning disabilities have above average intelligence. And I think this is the tragedy. And that's why I hate labels, because they stick. And when you put a label on somebody, it's hard to peel it off. And that label sticks with that kid all the way through. Why not just teach that little boy in a way that that little boy can learn? In other words, by more visual and tactile. And when you're doing a test on that kid, I often say, I'm going to test your left ear. I'll touch his ear. Put your hand up when you hear that. They can't learn from people who are talking like this on a mono, blah, 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 blah. No, they need an active, engaging teacher. And that's really important. And there's not enough male primary school teachers out there. There's not enough male speech-language pathologists. There's not enough men teaching kindergarten. There should be, but anyway, just like there's not enough women in engineering, and there's not enough women doing computer stuff. So we've got these biases, but that's why I had you cover the terms reliability and validity. Is a test always testing what it says it's testing? Is the dichotic digits test truly testing for learning disabilities, or is it basically testing gender? So, food for thought. Anyway, this completes our discussion on retrocochlear pathology. Are you having any questions? I've talked long enough, but are there any questions? We've covered the notes now from top to bottom. And the PowerPoint slides, I believe, have all just about been covered. So essentially, this kind of does it. But if you have any questions for me, let me know, and I'll do my best to answer. Good to go? All right, thanks. As always, good to see you both again. Next week, what we'll do is we'll finish this course with one session on pseudohypoacusis. That's going to be a trip. People who lie in a hearing test. Why lie? You wonder why, but they do. Anyway, it's been a slice. We'll catch you later, and we'll see you when we look at you. All right?
Bye.
Thanks, Doctor.